which target we are taking the MRI lesion as a target or the micro ultrasound?
It's not there.
What is the cost of this over neural ultrasound?
How confident you are with this device will tell us that.
Let's show a comparison between the micro ultrasound and MRI. Is there a case control study? Doctor?
A very warm and good afternoon. Respected senior faculty member, knowledge presence of Adawat sir. This is thank the North Zone USI hierarchy to allow us to have this session and present a few bare basics on micro ultrasound.
So, I have no disclosures. We just have this device, and
About the micro ultrasound itself, if you know in cancer prostate, better imaging is better imagination is better patient care. So the objective throughout has been to reduce false negatives, detect better and faster the suspicious areas, in real time to be able to track the suspicious areas, and to also to be able to track them over a period of time if you were to monitor the disease in situations of active surveillance, and find the resolution which is equal to the gold standard, which is MRI at present. And this also gives us an opportunity to understand the ultrasound system better. It is totally controlled by urologists and can be an ophthalmologist. So these are the so-called advantages of micro ultrasound. This was developed as the exact view. The evolution started as they thought that the resolution of ultrasound grayscale should go on increasing to better detect lesions. So they came up to the 21 megahertz Pro, and this was the first prototype by exact imaging, which was say 3 times more than the usual frequency, which is 7. So basically it is between 6 and 12, but 7, 8 to 3 was the logic. We wanted a 3 times better frequency rate, but this stabilized prototype at the level of 29 megahertz. And this is why the frequency of 29 megahertz, because the normal resolution that you get is about 300 microns, and the size or the architecture of ductular pattern of prostate is about 150 to 300 microns. So therefore they brought it to this particular point. So by an ultrasound scan, you can get an idea of the histological changes in prostate. You can get an idea on the histological changes of prostate plus the Rashley. So they did it by two things. They increased the frequency, the to output 29 by dams, and second thing, the bit that array in which the crystals, piezoelectric crystals were arranged was far more denser as compared to the conventional ultrasound. So this is a grayscale of micro ultrasound, and to say the least, it is not the most impressive grayscale. You see, I call it the dirty grayscale. If you get say, if the classic comparator for this is a BK ultrasound. We all love BK, used it for ages, and you see the grayscale of BK is homogeneous, so it looks beautiful. This is dirty grayscale. So for the first time when you see micro ultrasound, you are taken aback. You see, you don't see it as a smooth grace. So that kind of for the person puts you off. But if you look at it closely, look at the resolution, the peripheral zone, the central zone, the urethra. This is the urethra right here. This is the peripheral zone. This is the anterior muscular stomas at the here. So these all areas look very, very nice. Now the understanding of hypoechoic and hyperechoic area also differs slightly in micro ultrasound. So it is not our reading of a classic DSK. So again, better delineation of margins of prostate EQC. So one of our problems is that the MRI is done at some other place whom we don't know. Tomorrow we posted this patient for a radical prostatectomy, and we are trying to do a nerve spare based on somebody's understand. But this device also gives you a sense of good capsular understanding, which is very over a period of time you realize that the ability to identify capsule goes on increasing as the number of cases go on increase. Then it can visualize about 60 or 6 centimeters of depth of prostate. So any practically, that means practically any size of the prostate, maybe 150, 200 grams, can be visualized well. And you have an option to magnify it, like their highest magnification goes up to 30, and you can start this from 60. So as you keep on decreasing that depth, the magnification keeps on increasing. So this is a situation where you see the old needle tracks. So if you are doing a rebiopsy, you will be able to visualize the old needle tracks as well. So that is a very good thing about this particular, and also real time. So what is the guarantee in a smooth grayscale that you're not hitting the same target twice? But in micro ultrasound, because you see the needle tracks very well, in a fusion system, it is a software that guides you and tells you that yes, this was the mark of your old needle track. But the grayscale itself in micro ultrasound will tell you that here was your previous needle track, which you took a few seconds back. So that is one advantage. And in the second biopsy, you know that this area was already targeted, so you can consider to spare it. There's adequate evidence. So there is no dearth of evidence on micro ultrasound. About this 60 is a little older data now. Your 75 plus peer-reviewed manuscripts in major journals. Many of them are in the Q1 journals, and it is come into the guidelines in 2024. Now, this is the Achilles heel of micro ultrasound, understanding the grayscale patterns with reference to cancer blast. So now, like you have Pyramid grading system for MRI and the Primus grading system for micro ultrasound, and I'll take you through Primus 1 to 5. The analogy is same. 1 and 2 is benign, 3 is equivocal, 4 and 5 are more likely to be malignant. So this is the Primus 1 lesion. So this is the normal peripheral zone, and the appearance that you see is called the Swiss cheese appearance. So you see, this is the normal ductular pattern. This is the normal ductular pattern under a resolution of about 150 to 300 microns. This is how a ductular pattern will go. You will on occasion see that this ductular pattern is enhanced. That is, these ductular patterns will become more compact, like in this situation. So these are called the hyperductular patches. So basically, whenever you see, this is a ductule. This is a classic clearance of a ductule. So fluid containing thin-walled luminal structures packed together, these are ductular patches, and when they are spread apart, they are called the Hubble ductular patches. These are the hyperductular patches, and these are Primus 1 and 2 lesions. So most easy to identify. You just keep on doing ultrasounds for your OPD patients, and within 15 days, you should be able to identify them. Now, if I just remember this this is normal ductular pattern, this is hyperductular pattern, and now we both here. So in this, we all know what is hyperechoic. That means something which is brighter, reflects better. So something like this. So you see bright dots. So in this circular pattern, whenever you see bright dots, these are bright echoes, and these classify as Primus 3. So there are still not multiple bright dots, but there are small scattered bright dots. So if you were doing grayscale and a grayscale ultrasound, the analogy is sometimes you see small calcification between the peripheral zone and the benign adenoma. So that kind of calcification you will see in parts. So this is a good example of a region where you can see Primus 3 area. So this is the region where I'm not sure it can be cancer or it cannot be cancer. Look at this. Here the same thing is spread over a large area. Initially what I try to analyze is that 1.5 centimeters is the cutoff when you look at MRI. So I try to, though this scaling does not give us that, but I to get area of 1.5 centimeters. If this echogenicity spreads over an area of 1.5 centimeters, I thought it may be Primus 4. And then by backward integration, I realized that if it spreads over say 1.5 centimeters, it more often than not qualifies as a Primus. So distributed hyperechoic areas. And one more thing is mottled appearance. So you see, if you carefully observe, this area looks different than say this area or this area. And now I'm going to superimpose a cauliflower on this. So this is how a cauliflower lesion works. I go back again. Now you can you see a big rounded area here? Again I put a cauliflower. So this is the analogy where you see this variegated area over more than 1.5 centimeters. It is more like a primus 4 lesion. And the easiest to identify is primus 5 lesion. So the classic primus 5 lesions is this. So imagine your 4 fingers casting shadow. So these are my 4 fingers casting shadow. 1, 2, 3, 4. This is primus 5. Or the entire glandular anatomy is totally disturbed. You cannot see the glandular architecture. Here, you cannot see the glandular architecture anymore. That qualifies as a primus 5. So here you see that the glandular pattern is totally disturbed. So this is primus 5. Now let us take an example. This is a hypoechoic area. This is a hypoechoic area. Now we try to classify this. Can we see the normal glandular pattern here? Normal glandular pattern is something like this. So we cannot see. It is darker. That means it is hypoechoic. Is it casting any shadows? It is not casting any shadows, but the architecture is disturbed. So I would put it somewhere as primus 4.
Can I ask a question? Yes, sorry. Just when we do this hyperacute to people, you're always bringing the reference to something. So here in the prostate, the entire thing, obviously a part of it would be hypoechoic. How do you really correlate that this specific injury hyper is there some standard like the muscle curiosity or this just that?
So sir, like a case of transrectal ultrasound, in transrectal ultrasound also you don't have a reference. You never have a reference for unlike the abdominal ultrasound where liver and spleen act as a reference. For transrectal ultrasounds also you don't have a reference. The reference here is basic understanding of the ductular anatomy. That is the reference. So whenever you see a picture, because we are
Basic reference would be to the nest of the beer or a gland which is fine order. So you would compare it with that. But they could be just if they are involving the whole prostate, then probably it would be different. But if you are trying to find out a lesion within the prostate, then you won't have comparison with the rest of it.
yes, so exactly I say to read that point fully. It is the ductular anatomy that you learn to read, and in reference to the normal ductular anatomy, you consider it to be normal or abnormal. Now, in a case where the entire ductular anatomy is distorted or it is primus 4 or 5 or something, in that case, you don't need any tool. No tool is required to require your finger-graded biopsy can work. So it is basically without grace, the gray zone PSS or extended gray zones, say 4 to 15, 4 to 20. This is the area when we are trying how to cover. So this is the anterior lesion. This is an anterior lesion. Again, sir, this is the normal ductular anatomy. And in preference to this is dark and the ductular patterns are distorted. A bit about the probe itself. So it is the only probe which has capability of doing transrectal and transcardial biopsies. Exactly the same probe changing the position of the patient. And one good thing about this probe is that it is compatible with your linear grip. It is compatible with precision point and other market devices that are available. And even if you want to go see, so devices like these, devices like precision point, which are commercially available. Now there is one which is commercially available in India also. A South Indian manufacturer who gave it like a single drill, like something like a precision points, and that is also compatible with this. You can, with another important thing is you actually don't need fusion with this device. But if you were to do fusion, you can do a fusion also. you can refuse the MRI. I'll just show you how you can do it. So this is again plastic finger-like projections. And this is starry sky appearance, multiple dots, bright dots. So, so how you show a better example? How you actually do? We just see how do you do transperineal biopsy with this? Whereas basically the principle of doing transperineal biopsy remains see you can infiltrate the perineum with a local anesthetic agent, put the patient in Lipardini position, and then near the apex infiltrates on a local anesthetic agent, and they have a grid, the linear grid. So it is similar to a BK linear grid, or you could use any of the devices. Uh, uh, the- e- and So this is a comparison of how the needles with the this is visualization with the same probe. This is a hand-on transperineal, and this is at an angle, laterally directed biopsy. One good thing is that it always gives you a measure in both the views. It will give you a measure. So there are solid green dots that separate by a centimeter and which have a smaller separation also. So it will give you how deep you are going in both the planes. So that's how it will give you the separation, and then that will give you maps. So now when you put the MRI image into the software, what you do is you you put the fusion mode on, and then you move your probe towards the you could move your probes towards the say left. The left is the lesion. Move completely your probe towards the left and push the pedal, so it will mark the left. You do similar for the MRI image. Move it completely to the left and mark them. So now both the images get aligned. So as you move your probe, that image also moves. So you can do a uh, cognitive kind of a fusion. So that a cognitive assist can be used in this particular machine. So therefore, I was saying that you rotate the probe. Say if in this situation you are doing it to the right side, so rotate the probe completely to the right, mark that point, then rotate the MRI image to the right and mark that point. And then now the MRI image and your the ultrasound image are mapped, and then you can move your ultrasound along with that MRI will. But I'll say this strongly, you actually don't need a fusion with this machine. It is very, very intuitive. You'll be able to identify areas after a point in time. There's hardly that I actually feel like using fusion with this machine. So I think there are some examples which Kunkat sir will take you through later on. I'll not go into the examples. So this is something very, very important that have not validated this, but this is my present working guideline. So if there is something that is suspicious based on DRE and PSA, that is a gray zone PSA between 4 to 50. I just expanded that proper movement. And if there's, of course, if there is a DRE abnormality, then it's a totally different ballgame. I do a micro ultrasound first. So because it's a OPD patient, and at least in NPH, patient is not charged for it. So I have the liberty to do it on all the patients in this particular segment. If the micro ultrasound shows a -4 or 5 lesion, I will do a biopsy. I will not offer an MRI to this patient. If it is -3 lesion or below, then I will go an MRI. And if there is no lesion, then we can keep this patient on surveillance and follow him on PSA. And at the time when we feel that the PSA is under to rise, then again bring him back into the algorithm and then send him buyers. So I would say that this particular device helps us see the anatomical details better. It helps you visualize the different areas of prostate, pick up suspicious areas. Targeted biopsies can be done real time, and biopsy and diagnosis and biopsy can be done during the same procedure. It is completely under the control of ultrasound. And the future is that we may pick up clinically significant cancers better. If we be able to monitor disease, we'll be able to do active surveillance better. And this will practically head the way for focal therapy. Because it'll get the controls in our hand, and then we be able to predict lesions better, and eventually it'll head the way for apoptotherapy, and it was popularized. I go. So we comes. Right, so shit.
It hospitals procedure the patient.
Biopsy is a species. Species biopsies.
Up to the patient's away. If there any parents would be the private spot.
No, but we are a go ahead. That's model. So we thought put the return on an investment option.
What are the additional consumables you are using?
There were additional consumables.
Can is you like the standard?
Use a bionic. The band bioptic and the part disposal. The decolored pistol metal here. Abhishek, do you have a comparison between the micro ultrasound and MRI?
Is there a case control study about that?
I think there are many literature. We come to that later on. We will come to that later. And there are plenty, but that literature is repeat with that. You can quote some.
There is the author basically a lot of breather by clots and astrosida. These two books have done lot of work.
Only thing is that if they should buy this ultrasound, they can also be used for other guy. They what we use that ROI ajalka.
It has a abdominal bro, but again the problem is you have to learn to read.
That's but if you are like a per heavy institute and you want to do percutaneous access, I am not tried with this. So I don't tell when you but what I think is good. What I'm looking at is looking at
Layers of bladder with this. Every time I see a bladder tumor, I put this. I don't know where it will go, but I just started to look.
like I'm doing a feasibility like.
Yeah, but it has to go beyond GU to for a big corporate to buy this stuff. What is the cost of this over Nova ultrasound?
1.8 to 2
But they should use it if they use it in specialty, then they can we can.
But if you have a very high cancer prostate practice, this is the duty give you
It the sensitivity is basically
so parents 5 will give you a biopsy positivity rate of 78% or 82%, something like that. Primus score will be about 58% and Primus 3 will be about 33%, less than 33%. And we do a contrast. No, sir, this does not like the BK, it does not have a contrast. And what was the staging of the disease? Can it TDS sicker stage, the local staging it can do well. And it can replace MRI. Yeah, reparametrium, it can replacement. You cannot do regional, local regional you cannot do. Lymph nodes you cannot. That is a challenge. Sure, but local staging it will do very.
Right. Thank you very much. Dr. Abhishek. That was absolutely wonderful.